To the Supportive Care Services Live Lunch and Learn series. Today's featured speaker is radiation oncologist Dr. Eric Gross, and today he will discuss prostate cancer. Should I do surveillance, radiation therapy, or surgery? Let's all welcome Dr. Gross.
Thank you. It's nice to actually be speaking without a mask on, as we've had for the past 6 months. So my name is Eric Gross, a radiation oncologist here at Ironwood Cancer and Research Centers. I started with this practice in March. I'm in the Chandler and Gilbert offices. I previously practiced in Sun City West, right out of residency, which I did at the University of Arizona. And then I actually spent 12 years up in Denver, Colorado, working with a group of urologists at the Urology Center of Colorado. And so prostate cancer, bladder cancer, the other genital urinary malignancies being kidney and testicular cancer was the basis of my practice for 12 years. And so seeing prostate cancer for that period of time, you know, and really the changes in prostate cancer over that period of time was something that I wanted to review and feel very comfortable, managing. Prostate cancer is a unique cancer. It's the most common diagnosed cancer outside of skin cancer. Some statistics would, say it's even more common than breast cancer, but it's very common cancer. It's a cancer that's diagnosed most often in men that are age 65, 67. And so we say it's a kind of an older man's cancer. And so when we consider initial consultation, or where we say we risk stratify for patients, there are other variables that we have to consider, not just the malignancy. And that would be comorbid conditions that the patient has or may have. Many times if it's high blood pressure, hypertension, cholesterol issues, diabetes, and we consider life expectancy. And so when we look at patients, we should be calculating life expectancy, which is very difficult for any one individual, much easier for a group of individuals, but pinpointing life expectancy, I generally will use the Social Security life tables as a resource. There are a couple other resources that can be utilized. Sometimes you have to compensate for the comorbidities, or if a patient's very healthy, then sometimes we will, add an additional percentage based on that. But that's really where the conversation starts. So if a patient comes in to see me, the first question is really, where do they fall from a risk standpoint? And so when we risk stratify for prostate cancer, we're generally going to look at PSA, Gleason score, as well as the stage. And so let's talk about just cancer in general. Cancer really is a disease. It's a name that, describes disease that affects all systems of the body, and men, women, and children. But yet these diseases behave very differently, so the basis of cancer is it's a cellular disease. And so cancer is a disease of cells. What I explain to patients, well, what are patients? Patients are really just a bunch of cells. When you break down the human body, you have a cell, which is the basic unit of life, and cells clump into tissues. Tissues form organs. Organs comprise a complex organ system. But when you think backwards, we are all just groups of cells. Your liver, you can't live without your liver, but your liver really does what all the little liver cells do every day. So then you take cancer, a disease of cells. Well, how is cancer different? Well, cancer cells are different primarily in 3 ways. Number one, cancer cells don't look like normal cells, and that's the basis. We'll talk about the Gleason score. It's based on the appearance of these cells, and many times when you look at a cell, you can determine how aggressive it'll behave based on its appearance. So cancer cells don't look like normal cells. They don't function like normal cells, meaning, as I've described, our normal physiology, the way that we function, that takes place every day, is based on how cells function. Well, if cancer cells replace normal cells and those cancer cells don't function like normal cells, you or I will not function the way that we're supposed to. And then lastly, cancer cells are immortal. They never die. Where normal cell division is regulated, where cells divide and die, cancer cells will never die. And so you could take cancer cells, put them in a dish in a lab, give them everything that they need, and they will live really indefinitely. You know, we have cells that have lived, you know, and there's actually a cell line, you know, based on a book that I'll plug called The Immortal Life of Henrietta Lacks, and that's about a lady that had cancer that died, but her cells were used, you know, in science and thrive in many labs still today. And this is, you know, 80 years, 70 years after she passed away. So that's the basis of this disease that we're talking about. Is cancer is a disease of cells. And so commonly patients will say, well, what's my stage? And there's two common terms that we use with cancer. It's going to be stage and grade. Stage implies where does the cancer start and where does it travel? And then grade implies how does it behave? So the grade for prostate cancer is based on a Gleason score. Gleason scoring is confusing because there's a Gleason grade and a Gleason score. The Gleason grade can be 1 through 5, although we very rarely see 1 or 2. Most commonly, it's going to be a 3, 4, 5. And then the score is an addition of 2 numbers. So the 2 numbers that are added together to make the Gleason score, you know, result in a number that's generally 6 through 10. Most commonly, it's going to be 6 through 9. So we don't see 10 that often. And the 2 numbers that you have for a Gleason score imply the greatest number of cells. So for instance, if you have a Gleason 7, you can have a 3 plus 4 or a 4 plus 3. The first number just implies when they look at these cells in the microscope, so they do a biopsy, we're looking at the tissue to determine your grade. The cells that are most populous or most numerous, that will be the first number. So 3 plus 4. So when you look, can we step back for a minute? When you look at the Gleason grade, 1 through 5, 1 being the less aggressive, 5 being the more aggressive. So a 3 is going to be less aggressive than a 4. So if a patient has a Gleason 7, the 3 plus 4 is considered more favorable than a 4 plus 3, because the greatest population that they're seeing in that biopsy is made up of the less aggressive number 3 cells. It's a little bit confusing. People confuse grade and score all the time. Basically, it's just a number. Think of it like this. All cancer cells arise from normal cells. So if I know that I have a prostate cell that's normal and it looks like a box, and then I have an abnormal cell that doesn't look like a box, let's say it looks like a star, that's an aggressive cancer. Meaning if I can't really determine even what the original cell is, where it looks so abnormal, that generally implies a very aggressive cancer. And if you could picture a box and a box gradually turning into a star, that's really going to be your Gleason grade, your 1, 2, 3, 4, 5. Sometimes people read their pathology report and they see other terms like atypia. There's something called PIN. I won't even go into what that stands for, but think of a normal cell. You have your Gleason grades over here that all meet criteria for a cancer. There's a bunch of cells that are in between. And so really this is a continuum of abnormality from a normal cell to an abnormal cell. And so that's how we arrive at the Gleason, the Gleason grade, which determines how your cancer behaves. A Gleason 6 is considered low risk, a 7 is considered intermediate risk, and then 8 or 9 are considered high risk. Certainly if you had a Gleason 10, that's the highest risk that we see. We don't see it that often. That's an aggressive cancer. If you have a Gleason 6 or even less than 6, which sometimes we'll see on older pathology reports, that's obviously a very favorable cancer. And so that's one thing that we'll use to risk stratify, along with the PSA. So the PSA is a blood test, prostate-specific antigen, that's not specific to prostate cancer. So you can have an elevated PSA in the setting of cancer, but you can also have an elevated PSA, with regards to different labs, different days, infection, irritation, inflammation, ejaculation. So, it's not something at the end of the day that you can hang your hat on and conclude, well, that's a malignancy. Even larger prostates have a higher normal PSA. We account for that sometimes by calculating what we call a PSA density, using the PSA value with the prostate size. Older, as men age, we have a higher limit that we accept as normal for PSA. So like many things in medicine, there are very few black and white issues. It's more of collecting data and collecting information that then allows you to make a recommendation for the patient based on what I say, a body of evidence. So lastly, let's talk about stage. So stage with prostate cancer, historically there's two types of staging. There's clinical staging and there's pathologic staging. Pathologic staging generally implies the patient has had surgery, and pathologic staging, for the most part across the board, is more accurate than clinical staging, because clinical staging is based on either, in this case, a digital rectal exam, which is not perfect. When you feel a prostate, sometimes anatomically you can't feel the entire prostate. Sometimes you may feel, abnormalities that aren't necessarily related to prostate cancer where the biopsy is positive. Post-biopsy, you could certainly maybe feel changes based on the biopsy, whether it's a, collection of blood, a hematoma, collection of fluid, a seroma, where the digital rectal exam is less objective post-biopsy versus pre-biopsy. Many times I'll look and see what the urologist diagnosed when they did the rectal exam prior to the biopsy. So the digital rectal exam is considered the primary way to stage a prostate cancer clinically, and if you have advanced disease, you can certainly, feel sometimes when that cancer has breached the capsule of the prostate. In that setting, then that would be considered a more advanced cancer or a T3 cancer. If we have invasion into the seminal vesicles, that's also a little bit more advanced. Sometimes you can feel that rectal exam. If we have, let's say, a Gleason, 8 or 9 or 10, or we have a PSA that's above 20, then there's a higher risk of disease that's left the prostate. So that's considered metastatic disease or metastases. And so we may order other tests. Standard would be a bone scan or a CT of the abdomen and pelvis. Those are also considered staging studies, again, thinking, where did the cancer start and where does it potentially spread? And so all of these things, this is all information that I look at, before I walk into a room and I counsel a patient, based on what their options are for treatment. Keeping in mind that I look at the grade, the Gleason, the stage of the cancer, we look at the PSA, then we look at the patient's age, and then we also look at their health history. We say their comorbidities, okay? There are other things. A lot of patients will present. They've gone on Dr. Google, who we're all a very big fan of, including myself. I say that facetiously. And they say, well, how about a PET scan? My friend got a PET scan. And, keeping in mind that a PET scan, as I've already described, that cancer is really, this basis of cell abnormality, but these diseases behave very different, and they're all different cells. So PET scan across the board does not always apply for just any cancer, and there are multiple different types of PET scans. And so in general, standard PET imaging that we do, commonplace when we're staging more advanced, like head and neck cancer, lung cancer, some lymphomas, breast cancer, things like that, we won't use that scan even for advanced prostate cancer. There is a new scan. It's based on the way that it's the radio tracer that we use. This one's called fluciclovine, or the trade name is Axumin. That's specific for patients that have already been treated for prostate cancer. So let's say their PSA is rising and they've already had surgery or radiation. So in that setting, we can order a PET scan and get it approved. That's the other thing. Remember that even if we order a scan, if it doesn't meet the indication, then it will not get approved and will not get paid for. And these scans are not inexpensive. So PET scanning is a unique way that we risk stratify in a unique set of patients. And then another thing that we're doing now that gives us very good information is we do these genetic analysis type tests of the tissue that's obtained at the time of biopsy. So one that we use frequently, not just with prostate cancer, is called Oncotype DX. There's another one called Prolaris. There's one called Decipher. I don't want to endorse one over the other, but what these allow us to do is really allow us to personalize medicine. I would frequently use these, especially in considering patients for active surveillance, because again, the analogy I would use, if I'm using, a rectal exam, a PSA, and a Gleason score, and I have to put you into a category so that I can counsel you regarding treatment options or, surveillance, then that's like a zip code. There's a large pool, it's a big area, but I've got you kind of, set into an area, but I don't really know your address. Well, a genetic test, if I can take your tissue and send that off to a lab, the genetic test is going to tell me specifically where you lie along that spectrum. So it's not uncommon to have a lower risk cancer that's really intermediate or higher risk, that's just masquerading as a low risk based on those less personal variables of PSA, digital rectal exam, and Gleason score. So especially if I'm counseling a patient on active surveillance, I want to identify someone that may actually carry higher risk and then ideally is not suited for a program of active surveillance. And so those are the things that go into analysis, or we say risk stratification. It can get pretty detailed at times. Ultimately, that leads to the conversation that then I have with patients. And one thing to keep in mind as well, we use the term cancer, but for a Gleason 6 prostate cancer in an individual that's older, we've even debated, or there's been discussion, that maybe we shouldn't call it cancer, because cancer strikes fear in individuals, rightly so, because many patients don't discern between a low-risk prostate cancer and a lung cancer or pancreatic cancer, and those are very aggressive cancers compared to prostate cancer. And so I try to educate patients, but sometimes patients just come in and they say, look, I got cancer, I don't care what we talk about as far as surveillance, I just want to have it treated. So at the end of the day, you have a conversation like that, all this other stuff really doesn't matter, because the patient's quality of life could be negatively impacted based on their psychological, in just their perception of what this cancer would do if they were to watch it. So let me segue then into, the treatment options for prostate cancer. So, in the right individual, active surveillance is a very reasonable option. And we talk about surgery, which is a radical prostatectomy. I won't go into a lot of detail, given that I'm not a surgeon. I'm sure the surgeons appreciate that I'm not giving you a lot of detail regarding surgery. I have excellent colleagues within Ironwood that I would refer you to discuss surgery more in detail. Then we do radiation. There's two types of radiation. We do radiation with a machine. It's called external beam radiation, or radiation with seeds. And that's called brachytherapy or brachytherapy. It's a Latin term. Brachy is B-R-A-C-H-Y. It implies at close range. So essentially, a machine that generates a beam travels through the air to your target. That's a form of teletherapy, where the brachytherapy, you're taking the radioactive source, you're putting it right into the prostate where the cancer resides, again at close range. So those are considered the treatment options. We use a term frequently called the standard of care. You know, we practice evidence-based medicine. You know, we conduct research here at Ironwood, you know, so that we're not just, you know, propagating medicine the way it is today, but we're trying to find better ways to advance the treatment of tomorrow. With that, then you compile your data and you develop these pathways or these consensus-based guidelines that really all of us that practice evidence-based medicine should subscribe to, because it keeps us all moving forward versus, you know, less collaborative. So consensus-based guidelines, you know, we use generally National Comprehensive Cancer Network, or NCCN. So you might hear, you know, a doctor say, well, based on NCCN guidelines. Many times insurance companies will look at NCCN guidelines based, you know, for the basis of approval, especially newer things. I may use NCCN guidelines if I'm trying to get something approved, you know, with an insurance company. And so if you go to any practice, you know, anywhere in the country that practices evidence-based medicine and you have the same diagnosis of prostate cancer, we as physicians should all basically be telling you the same thing. So based on that risk stratification, you'll come in, and if you're a good candidate for active surveillance, you know, I generally talk about that first with patients, you know, and I try to reassure patients, especially if they're older, that, you know, many times in the day and age of PSA screening, you know, we're identifying prostate cancer that has no symptoms. So we say that that's asymptomatic. It was diagnosed on an elevated PSA. They get a biopsy. The biopsy is a Gleason 6. You know, let's say we can't feel anything on their rectal exam. So that's what we call a T1C. And the PSA maybe 4 or 5. You know, anything less than 10 is considered favorable. You know, in a Gleason 6 cancer in an elderly male, you know, certainly older than 65, but really active surveillance is advocated for, you know, all age groups. You know, I generally will say, you know, how do you feel about active surveillance? You know, when you think about the pros and cons of active surveillance, what I tell patients when they come in and they have no symptoms for a cancer, or no symptoms from this cancer, well, I tell them that by treating them, whether we did surgery or some type of radiation, you know, I can't make them feel better, but any treatment has potential risks, you know, and so that's one of the, I mean, I think the greatest benefits of pursuing surveillance, at least initially, is, you know what, especially if they have, you know, excellent urinary quality of life, excellent bowel quality of life. And some men are sexually active, some aren't. The younger guys tend to be more often, you know, from an erectile standpoint or erectile dysfunction. These are all domains that carry greater priority in different individuals and all have to be considered. I mean, you know, usually we're not talking about fertility, but fertility, you know, can be an issue for some of the younger men diagnosed with prostate cancer. So I generally, if patients are open to the idea, I generally will say, hey, why don't you give surveillance you know, give it a shot for at least the first 6 to 12 months. And usually, and this is where everybody does things a little bit different, you know, they'll do a confirmatory biopsy, usually within the 6 to 12 month time frame. And I say it's a confirmatory biopsy because based on one biopsy, we may say, you know, we believe you're a candidate for surveillance. Let's confirm that on a subsequent biopsy. And most guys are comfortable with that. Some might call. I say, hey, you know, this hasn't closed this door. You know, if you opt to proceed with treatment, or you say, hey, after 2 months that my quality of life is poor, I'm thinking about this all the time, I'm worried about this cancer, you know, then we can certainly proceed with some type of treatment at that time. But, you know, I generally, you know, try to nudge them a little bit, you know, if they're open to the idea of doing surveillance, because, you know, it's really based on data. You know, it's really, you know, taking a step back from treating cancer, you know, and being able to say that we identify that this is a disease that, you know, is, we would say, heterogeneous. If the disease was the same for everybody, it would be homogeneous. We would treat it the same, but we know that there's some very slow growing indolent prostate cancer, but then there are also some cases that are much more aggressive, and we have to be able to determine, when to make a recommendation of treatment versus when to make a recommendation of surveillance. So surveillance overall, I think is very favorable in the right individual. It's gaining traction, no question, as we get more data regarding long-term follow-up, especially for younger men. One of the cons, I would say, though, is active surveillance implies that a patient is compliant with follow-up, and it's only successful in that setting. So if I have a patient that it's difficult to reach, maybe has some volatility in their personal life, where I'm not sure they're going to be around, are they going to be compliant, following up with blood tests, follow-up rectal exam, and then subsequent biopsy. And sometimes when I mention to men that they'll have to have a repeat biopsy, they say, well, that to me is the deal breaker. I'm not interested in having another biopsy. And biopsies are just as variable as people. I have some men that have told me, I will die of prostate cancer before I'll have another biopsy. I have other guys that fall asleep. Those tend to be the older guys. So again, a lot of variables to consider. It's a very personal decision. So let's move on. So active surveillance. Active surveillance is ideal with very low risk and then low risk. We also factor in life expectancy there. If you have someone that has 5 years of life expectancy, we may not even do a program of surveillance. Surveillance implies you're actively monitoring the cancer, and at any sign of change or progression, you would potentially intervene, which should not compromise your overall outcome. Where if it's someone that has limited life expectancy, we just say observation, meaning we know it's there, we're not even going to monitor it because we're not going to treat it unless it became symptomatic, and understand that progression could honestly take place over many, many years. So then, and this also depends on the risk of the disease. For the most part, if you have high risk disease, you're not going to be a candidate for active surveillance. Again, based on life expectancy, this is going to be primarily very low, and even favorable intermediate, although favorable intermediate, which can include men that have a Gleason 3+4, or someone that has maybe a PSA between 10 and 20, but their Gleason score is 6. These are individuals that are entering a little bit more of a risk in that intermediate zone, and so maybe less appealing to younger guys. When you have younger guys with greater life expectancy in front of them, the stakes are a little bit higher, just based on that life expectancy. They also tend to have fewer health issues, so the comorbid conditions are not as important to consider. So when considering surgery versus radiation, understand that for the most part, they're considered equal. The outcomes are considered equal. As I explained to patients, the outcomes of treating and curing prostate cancer are more closely related to the risk versus what they opt to pursue. So lower risk does more favorably long-term than intermediate risk, which does more favorably long-term than high risk. It's a different discussion. Many patients will talk to a surgeon and talk to a radiation oncologist. We tend to do surgery more often in younger men, mainly because surgery, it is invasive, it has some risks. And again, as men get older, if they have those comorbid conditions, maybe they've had a heart attack or they have other issues, then they become less favorable from a surgical standpoint. Radiation, as I mentioned, comes in 2 types. There's radiation with a machine, radiation with seeds, where we either put seeds into the prostate. That's a form of what we call LDR brachytherapy. I won't go into too much detail here. Or we also do a form of HDR brachytherapy where the radiation source is temporary. So we place catheters into the prostate, and then the source is kind of hooked up to a machine that houses this source, and then the source kind of sits along what we call these dwell positions along the catheter. I think in general, and again, these are lengthy discussions, and it's almost an overwhelming amount of information when I meet with people initially, because you can go down as I say, a lot of little rabbit holes, regarding each of these types of treatment. There's a lot of detail to be explained. I mean, in general, we think about urinary symptoms, bowel symptoms, and then erectile dysfunction, which you can really have with either surgery or radiation. I would say, in my experience, erectile dysfunction really depends more on the baseline erectile function of the individual prior to either surgery or radiation, and then that patient's age. I mean, unfortunately, older men don't do as well as younger men, and that's with a lot of things. We tend to see a little more urinary incontinence with surgery. I think that in my experience, again, many men focus on incontinence. I hear a lot of men saying, well, I'm not going to wear a diaper. I'm not interested in surgery. I'm not going to wear a diaper. And, I try to make them see that this is a glass half empty, glass half full issue. And guys are always looking at the glass half empty, or most of the time they are, when I remind them that it's usually glass half full, meaning that most guys are continent post-surgery, but they're just focusing on that true minority. And even the true minority that's incontinent, it tends to be stress incontinence. So that's coughing, laughing, sneezing, lifting. And I again, facetiously remind everybody that as we age, everything's going to be deteriorating. So we all might start dribbling and piddling, without having to consider any of these options. So again, contrasting both, it can be a lengthy conversation. Seeds have advantages, disadvantages. Think of this in general when we're treating cancer, really any type of cancer. So lower risk cancer, because it's less aggressive, may require less aggressive treatment. So many times you're very confident that patient may have surgery. They're going to be cured with surgery. I might do seeds alone in that patient. I might do radiation with a machine alone. But as you, again, follow along this continuum of this abnormality of these cells as they become more aggressive, then your treatment here may not be adequate for a cancer that's more aggressive here. And so think of it as, the more aggressive the cancer, then the more aggressive your treatment. So it's like a kind of a punch and a counterpunch. With radiation, many times as we get into the intermediate risk, there's two types of intermediate risk, which I won't go into here, but there's favorable and unfavorable. Then you get into high risk, and then there's very high risk. There's regional, which implies that your lymph nodes are involved, and then there's metastatic. So when I get into, especially that unfavorable intermediate risk, well, I won't do seeds alone in that setting. I might do seeds combined with the radiation with a machine. We call that combination therapy. Or now I might add a short course of hormone therapy, which again, that's another talk, but hormone therapy just implies that we're suppressing testosterone. Testosterone fuels those cells to divide. And so by decreasing the testosterone, we can get a better response from the radiation. And so as we get into that unfavorable intermediate risk, I might add hormone therapy to radiation, either with seeds or with the machine. I might add the seeds and the machine together. As we get into high risk, now I'm certainly adding the hormone therapy. I might actually do hormone therapy with the machine radiation and then using the seed radiation as a boost. In the very high risk setting, sometimes we add chemotherapy. That's been something that's been part of the guidelines, not part of the guidelines. It's part of the guidelines again. Certainly might do that in a younger individual. I may extend my radiation field now to include the pelvic lymph nodes. There's even an option, there's an oral type of medication that manipulates the production of testosterone called abiraterone that we use sometimes in the regional risk setting along with radiation. And so it can get the conversation can get very, convoluted when you're trying to kind of go over all these options. So it's better to give an overview. Also, in my experience, when I first meet with patients, obviously we only absorb a fraction of what we hear, and especially if a patient didn't fully understand something, sometimes patients come in and they don't understand that they're high risk, and then they'll say, So am I to understand that I'm high risk, and when you confirm that, then sometimes they're not really listening. They're focused more on just that news that they just received, and so sometimes it takes an extra visit. But conversation, we usually work closely with our colleagues in urology regarding what their feelings are. I get their input many times. I mean, there are other factors. Is the patient a candidate for anesthesia? How big is their prostate? Do they have a lot of urinary symptoms to start with? Do they have a lot of bowel symptoms to start with? Bigger prostates, generally aren't good candidates for a seed implant because you can have more urinary morbidity. Sometimes, things like blood thinners enter into the conversation regarding whether or not they can have a surgical procedure, given that the prostatectomy, which is mostly done robotically, that's obviously a surgical procedure. The seed implant, that's same day surgery, but can be done different ways. I generally did it under general anesthesia. So these are all the things that we consider, when evaluating patients. And I think the most important thing, initially when seeing someone is to just start the dialogue and make sure that you establish a good rapport so that they can continue to, kind of bounce things off of you as they make that journey forward, through the decision process, then the treatment process, then the aftercare, as we call it. I'm a pretty accessible individual where many times I'll give patients my email. I remind them not to get too upset if I don't answer, just because sometimes it ends up in my junk email. But I try to keep the dialogue open so that they can feel comfortable, just shooting off the email when they have the thought, because many times you're going to be sitting there and, I forgot to ask them this. I don't have a problem giving out my cell phone. Patients can text me, hey, what do you think? Not everybody is open to that, but I think, in today's world with the amount of information that we have, I think that's, kind of the way we're headed in general. So today, I just wanted to keep it relatively informal, and give everybody kind of an overview of what's happening in the world of prostate cancer. I'm happy to meet with anybody. I'm happy to do another talk if overwhelmingly people felt, hey, I'd like you to, elaborate a little bit more on this topic or on that topic. But at this point, I think I'd like to see if anybody has any questions.
Dr. Gross, thank you so much for that informative presentation. We actually do have quite a few questions from our digital audience. Okay. The first question is, how long can you be on surveillance before treatment is needed, and is treatment always needed after surveillance?
Great question. About 2/3 of individuals will not require treatment. So we got to figure it's about 1 out of 3. I've seen some men on surveillance, and they have to remember that as surveillance has gained traction, we get more experience, or we get larger numbers of individuals, so we get greater data collection. I've seen some men on surveillance for the better part of a decade before they actually progress to a point where they require treatment. But the basis of surveillance is that if you're compliant and we detect progression, then it should not compromise the overall outcome. Now, keep in mind that this is a recommendation for the masses. It's not necessarily a recommendation for everyone individually, meaning that, when you debate the pros and cons of surveillance, one of the cons would be, could your cancer progress from a low to, an unfavorable, intermediate, or high risk within the time frame and being compliant? And that can happen.
The next question is active surveillance only an option in the case of prostate cancer?
So, as far as I know, I certainly am not familiar with as robust a program, from a surveillance standpoint. Now, we are looking, for instance, with breast cancer. Breast cancer generally, these individuals are diagnosed on biopsy, and then they may undergo a lumpectomy, so that's considered breast conservation surgery, and we're looking at omission. So we do adjuvant radiation in that setting. So we do look at omitting, certain therapies with patients that are older with more favorable disease. But I'm not familiar with a program of surveillance for another malignancy as robust as prostate cancer.
Thank you. And can I receive radiation in the same area if I have cancer recurrence or a secondary cancer?
So the answer is yes. What happens? So keep in mind, prostate cancer, high likelihood of cure, especially in the lower risk individuals, but you do have recurrence. If a patient has had a prostatectomy or had that prostate removed, then many times we use radiation as a salvage. So anything you use as a second opportunity to cure that cancer is going to be considered salvage. So you may undergo a salvage, salvage external beam radiation. So that's pretty commonly sequenced. If I radiate the gland, then usually we'll consider, again, now, if you have a recurrence, first of all, many questions need to be answered. And a lot of patients ask me to say, well, what happens if the cancer comes back? And I'll say, this is what I need to know. What year are we talking? Is this 1 year, 5 years, 10 years later? What's happened with that individual and their health over that period of time? How well did they do with the initial treatment? Do they have any long-lasting treatment-related sequelae? Have they had a CAT scan? Have they had a bone scan? Are they a candidate for a PET scan? If all that's been done, have they had a repeat biopsy? Have we confirmed that that's a recurrence of the cancer? And so all of these questions need to be answered before I can inform them what the potential options for treatment are. And honestly, sometimes it may be no treatment, maybe just observation. Let's watch the PSA. Let's see how quickly that's going up. I think the question was referring also to a secondary cancer. Well, yeah, a secondary cancer, the risk is there. And what is that risk? It's very difficult to quantify. I mean, I've heard, 0.5% per year. The risk would be, potentially a rectal cancer or a bladder cancer. Sometimes it's hard to tease out variables like smoking. Smoking is the #1 risk factor for bladder cancer. If the patient's had radiation, is it attributable to, the smoking risk? It's hard to say. It obviously has to be in the field of radiation, where the dome of the bladder tends to be away from the field of radiation, so it's less likely to have a cancer, an induced malignancy from radiation at the top of the bladder. That gets to be a little more complicated, whether you would be a candidate for further radiation. The other thing about radiation is that it depends. The body forgives. We call it tissue forgiveness, over time, but it's not well quantified. I can't say specifically. I can't look at a chart and say, well, you had radiation 15 years ago and you had this dose, but over that time, I can take off this dose. So again, all of those things are considered. But to directly answer your question, I have done some salvage brachytherapy where I've actually done an implant after the patient's had external beam radiation. I have salvaged some cryotherapy patients that had initial cryotherapy, which isn't done as frequently. That's again something that may be gaining some traction, but historically that hasn't been, one of the common, it hasn't been as common as surgery or radiation with a machine or radiation with seeds. And so I have salvaged some patients using external beam radiation post-cryo, but more routine, patients that have external beam radiation are salvaged with cryotherapy. Some could be salvaged with surgery, although that can be, difficult. You can have a higher risk of maybe urinary incontinence and erectile dysfunction. So, I mean, it again just depends on a lot of different variables.
Thank you. The next question, should patients start screening early with a family history of prostate cancer? And if so, at what age?
Interesting question. We are more cognizant of asking about family history, and some patients now are eligible for familial testing. We call that germline testing. One thing that a lot of patients confuse is when I talked earlier about the genetic assessment of tissue being, with Oncotype or Polaris or Decipher, they confuse that with the genetic testing where we're actually looking if they carry a mutation that's in the germline, or that's a familial risk. There are certain, when you see clustering of men, in a family, that's going to be generally your first degree relatives. You'll see it, father, uncle, brother, in their earlier, usually in their 50s, you'll see those individuals. That's most likely a familial mutation. In that setting, certainly, and I defer to my colleagues in urology because they're the ones that really do the screening, but sometimes we recommend a baseline at age 40. So that's a digital rectal exam and a PSA, and it doesn't necessarily mean that you'll have to have, annual screening or follow-up after that. It really depends on what they see, at age 40, but that's something honestly that changes routinely, and guidelines for screening, even looking at the last 10 years, speaking out against PSA screening routinely for men back in 2010, and they've actually reversed, those recommendations just in that time frame. And so that's something that you really have to stay on top of and see what the current recommendations are.
Thank you. The next question, can I expect any long-term health risks from radiation?
Sure. Radiation is not just bottled sunshine. I mean, the way that you have to understand surgery and radiation is you can have side effects with either one. Some people perceive radiation to be more favorable because side effects develop over time. Where surgery, patients go in to get the prostate removed, they come out, they have a catheter. It takes a while to regain continence once that catheter has been removed. Erections are the last thing they're kind of thinking about post-operatively. From a radiation standpoint, now if patients are on hormone therapy, generally when you take away testosterone, erections are impaired from the loss of testosterone, libido, goes down. So setting that aside, if you're just doing radiation, many men can maintain, adequate erectile function, while they're getting radiation. And so they think, well, why doesn't everybody do this, compared to surgery? Well, just give it time, and you have to follow these patients out a longer period of time, and you'll see that, especially from an erectile dysfunction standpoint, it's probably about 50-50 in most patients, again, looking at their baseline function and their age. And so the follow-up, is important. So erectile dysfunction, even if patients have erections that are adequate for intercourse, I tell them your erections will change. I mean, it may be more difficult to attain an erection or more difficult to sustain the erection. The ejaculate changes. Many times the consistency or the volume, or it may just dry up. We call it dry ejaculation. Some men aren't prepared for that. Clinically, just talking to men over years, they say, well, my orgasm is not as intense. The sensation is a little bit different. I mean, these are not things that you have volumes of data to reference. I mean, this is just your clinical experience and what patients are telling you. There are two very good quality of life papers. Sanda, S-A-N-D-A, I believe Martin Sanda is the first one. It's a New England Journal paper, and it looked at this cohort of patients that have had either surgery, seeds, or radiation with a machine. And I think that's a paper that we all reference from a quality of life standpoint. So that was actually looking at the short-term quality of life with the different treatment options. And there's another New England Journal paper, I don't recall that author's name offhand. That was a long-term follow-up looking at 15 years after having surgery versus radiation. So those are very good resources that we have independent of the institution that we can say, from that paper, I would say, maybe 5% of individuals will experience, urinary incontinence, post-radiation. That can develop over time. There is a risk of having radiation proctitis, where patients can have, it's usually bleeding with bowel movements, and that incidence, depending on the different population that you're referencing, that incidence may be, at least 5%, but sometimes a little bit higher, depending on, again, the individual that, may have diabetes. Again, if it's someone that's diabetes, sometimes they have impaired wound healing. Older individuals, just may not do as well with recovery if they've had any damaged tissue. But there are a lot of factors. Again, you see the patient, are they constipated, are they straining, you correct any of these issues. Sometimes you'll use a hydrocortisone suppository. I'll usually have my colleagues in GI evaluate the patient, ensure that there's no concern or there's anything else. I mean, I generally ask patients if they had a colonoscopy prior to radiation, because obviously rectal bleeding can be a sign of a colorectal malignancy. And so I like to have that done prior, so I don't think about that if the patient talks to me about rectal bleeding. There's something called argon plasma coagulation, where they can go in and they can try to ablate any vessels that are bleeding. If persisting, rectal bleeding is an issue, then even sometimes hyperbaric oxygen, can be a benefit. But it's relatively rare to have patients progress to that extent. So think long-term, could be rectal bleeding, could be urinary incontinence, but most likely it's going to be erectile dysfunction.
And for our final question, how and when will I know if I'm cured of cancer after radiation?
That's a good question. The term we use frequently in the clinic, is NED or no evidence of disease. The PSA pattern, understand PSA is probably one of the best, if not the best tumor marker we have. Even though it's not specific to prostate cancer, the PSA pattern post-surgery very different than post-radiation. For the most part, post-surgery, that PSA goes to undetectable and it should stay there, and that's 6 weeks post-operatively. With radiation, PSA pattern is a little more difficult to decipher because you generally don't reach the low point for 18 months on average. That's called a nadir, N-A-D-I-R. So you're looking for that patient to nadir. Sometimes they may nadir past 18 months, maybe beyond 2 years. We see that more often in patients that have very low volume disease, because you're really radiating mostly normal prostate, and that tissue is not going to respond as quick as cancerous tissue. And so sometimes you scratch your head a little bit. I remind patients that one lab value, you don't hang your hat on anything. Sometimes you have to step back. You have to look at what is the overall trend. Patients probably get a little upset with me because I don't use the term cure loosely. I generally say you have no evidence of disease, NED. Low risk prostate cancers can recur late, so even though it's a minority of patients that recur, it could be in that 10 to 15 year range. I mean, higher risk individuals, if they're going to recur, that's usually declared earlier on. So I think they can breathe a little easier after the first few years post-treatment, but I think it depends on the doc that you talk to. Some patients aren't happy with me because I don't christen them with the term cure, but I try to put it in perspective. I'll see a guy that has, a pack of cigarettes in his pocket and a belly out to here, and he's telling me how grateful or how relieved he is that we found, his Gleason 6 prostate cancer that, from my standpoint, I don't even consider that. I think of this patient's cardiac risk. That patient's a walking time bomb. So I try to put it in perspective, and even though I don't come out and say, you're cured, I would say, if I were you, I wouldn't give this a second thought.
Wonderful. Dr. Gross, thank you for your time and this valuable content. And I'd like to thank our digital audience for joining us for the Lunch and Learn presentation today. There will be a replay of this Lunch and Learn on Ironwood's YouTube and social media channels. For more information regarding our supportive care services, classes, and events, email us at wellness@ironwoodcrc.com. Thank you.
Thank you.